Thank you for allowing me to present our work. Here are our disclosures. Compliance and distensibility of hollow organs may help us understand how to prevent postoperative dysphagia after laparoscopic fundoplication. Distensibility represents the relative change of a cross-sectional area of a hollow organ per unit of pressure, a measure of tightness. Gastroesophageal junction compliance can be understood as the ability of a hollow organ to dilate and increase in volume with an increase in pressure, a dynamic representation of food bolus transit through the gastroesophageal junction. Shown here are examples of compliance. Low compliance represents an increased stiffness, while high compliance, a completely pliable hollow organ. Finite compliance can be applied to the gastroesophageal junction. So impedance planimetry, based on the functional lumen imaging probe, FLIP, measures the dimensions and pressures of the gastroesophageal junction. The balloon catheter shown here inserts through the gastroesophageal junction, resulting in the corresponding image on the right with the red arrows indicating the gastroesophageal junction. The impedance planimetry system can calculate the tightness of the lower esophageal sphincter, known as the distensibility index, by dividing the cross-sectional area over pressure, a single plane. So compliance can also be calculated by the impedance planimetry system by dividing over here change in volume over pressure sections of a tube. The measurements of compliance have not been analyzed during anti-reflux surgery. So we aim to describe our institutional experience in utilizing impedance planimetry to observe the changes in gastroesophageal junction compliance during anti-reflux surgery and hypothesize that gastroesophageal junction compliance is a better predictor of patient-reported outcomes. So we included patients who underwent laparoscopic fundoplication and impedance planimetry evaluations from April 2018 to June 2021. Our FLIP protocol includes utilizing the 40 milliliter balloon-filled no pneumoperitoneum measurement. Our patient-reported outcomes includes reflux symptom index, which assessed for atypical symptoms of GERD health-related quality of life questionnaire, which assessed for typical symptoms of GERD, and dysphagia score. So we had 144 laparoscopic fundoplications and impedance planimetry evaluations, which includes Nissen and Toupet fundoplication, our sample size of 22%, 78% Toupet fundoplication respectively. At hernia reduction, our mean distensibility index was 6.5 and mean compliance 168. Upon crural closure, the mean distensibility index was 2.8, compliance 79, and fundoplication, mean distensibility index 3.7, and compliance 90. There was a general reduction in distensibility index and compliance from hernia reduction to fundoplication. Compliance of the gastroesophageal junction was shown to be strongly positive, had a strong positive association shown here on the scatter plot. Therefore, the higher the compliance, the higher the distensibility, and vice versa. Upon comparing the compliance and distensibility index at all time points during the operation, both measurements displayed similar trends. This trend was also demonstrated when the cohort was separated into Nissen and Toupet fundoplication. So here, compliance ranges were separated into 3 groups with a compliance of less than or equal to 79, 80 to 92, and greater or equal to 93, indicating low, ideal, or high compliance. Upon 1-year follow-up, patients in the ideal group reported the lowest, i.e. the best, reflux symptom index, GERD, HRQL, and gas flow score when compared to the other 2 groups. This meant that these patients had better symptomatic control of their atypical and typical GERD symptoms after fundoplication. The lowest compliance group had the highest rate of dysphagia out of the 3 groups at 1 or 2-year follow-up. So limitations of our study includes, being a small sample size for comparison. Quality of life surveys are sent electronically on a routine basis to our patients. However, response rates did vary at all time points, which may introduce bias. Compliance was not always calculated by the impedance planimetry system, possibly due to the balloon not being centered on the lower esophageal sphincter or the balloon pressure being too low. So those calculations were done manually. Our practice, as you saw in terms of our sample size, selectively performs Nissen fundoplications, which led to the majority of Toupet fundoplications in our sample size, which may affect our analysis. Finally, there is a lack of objective data in the resolution of GERD, such as postoperative acid monitoring or endoscopy, unless clinically indicated. So, currently, our analysis revealed that the gastroesophageal junction compliance and distensibility index are strongly associated with each other and follow similar trends throughout an anti-reflux operation. Therefore, we cannot definitively say that one is a better predictor versus the other. Both, in a sense, provide similar information, however, to different biomechanical interpretations. The distensibility index provides an objective measure of gastroesophageal junction tightness, while compliance represents the gastroesophageal junction's ability to accommodate passage of food, liquid, or gas. Gastroesophageal junction compliance of 80 to 92 revealed the best patient-reported outcome scores, and avoiding a compliance of less than or equal to 79 may prevent postoperative dysphagia. Thank you.